Good morning. Welcome to the lecture on trauma, stressor-related and dissociative disorders. The objectives of the chapter include describe the symptoms, epidemiology, comorbidity, and etiology of trauma-related disorders in children. Discuss at least 5 of the neurobiological changes that occur with trauma, and apply the nursing process to the care of children who are experiencing trauma-related disorders. Looking at trauma-related disorders in children, you can have various clinical pictures. First may be a post-traumatic stress disorder. It can exhibit as a reactive attachment disorder. And another symptom is disinhibited social engagement disorder. So what is post-traumatic stress disorder? So that means you have a stressful event, right? So the child is exposed or her caregiver was exposed to an actual or threatened death, serious injury, or sexual violence. And based on the exposure to that actual or potential threatening experience, a child exhibits some symptoms such as flashbacks or nightmares, or avoid this situations, or have negative mood. So that is known as post-traumatic stress disorder. And these post-traumatic stress disorder symptoms, usually this condition lasts at least 1 month. And they directly experience the traumatic event, or they might have witnessed a traumatic event, or they may become aware of some close friends or family suffering a traumatic event, or it may be due to repeated exposure to a traumatic event. So based on those clinical symptoms, those symptoms are categorized as post-traumatic stress disorder. Moving on to reactive attachment disorder, it may be due to constant neglect or severe neglect during the child's year, that first year to first 5 years of life. Your child is developmentally at least 9 months of old, and child is severely emotionally withdrawn with adult caretakers. They don't even go to adult caretakers for support or care. They have minimal social responsiveness, and it may be due to severe neglect they experienced, due to chronic lack of adequate emotional care, and instability from having frequent change in adult caretakers, as in case of like orphanages, certain orphanages where there's no adult caregiver, or being raised in settings that severely limit the availability of attachment to adult caretakers. So I have posted some videos or web links in the web resources in this week. Please look at those. This gives a beautiful representations of children, how these children had various symptoms based on their constant neglect and abuse that they had. Moving on to disinhibited social engagement disorder. Disinhibition. Inhibition means when you see a stranger, you have the inhibition to just go to that stranger. But disinhibition means you do not have that inhibition. You just go to anybody. So it is manifested by children's pattern of seeking out and interacting with unfamiliar adults. There's a lack of reticence when interacting with unfamiliar adults. Overly familiar physical or verbal behavior with unfamiliar adults, and little regard for reconnecting with adult caretakers, even in unfamiliar environments, and unhesitatingly accompanying unfamiliar adults. That is what is characterized as disinhibited social engagement disorder. Looking at the epidemiology, about 5% of adolescents is shown to have PTSD. And the prevalence among girls is higher. It is about 8%, whereas in boys it's about 2.3%. There's an alarming relationship between PTSD and sexual abuse. Those who were sexually abused, about 90% had PTSD. And those who were exposed to shooting at school, about 77% have PTSD. And those who have exposure to community violence, about 39% had PTSD. Moving on to comorbidities, based on the traumatic experience they had and their disorders, they have higher exposure to other comorbidities such as phobias, somatic problems, impulse control, identity issues. They have learning and attention problems. They have behavioral issues, sleep disorders, depression, suicide attempts, and substance abuse problems. And because of these comorbidities, these children may be subjected to medications, punishments, and inadequate responses that re-victimize and stigmatize the child. Furthermore, looking at the etiology, looking at genetics, we see that early adversity can cause some alteration and methylation of the DNA, and it can significantly affect how we respond to the stressors. Furthermore, prenatal or the parental nurturing plays a significant role in how we regulate or respond to stress. So if in the absence of parental nurturing, the children have difficulty with attention and following directions. They are more likely to engage in high-risk behaviors as teenagers and show increased aggression, impulsivity, and weakened cognition. Moving on, neurobiological. First 5 years of life are the most critical period, is the most critical period of a child's development. During this first 5 years of life, a child is vulnerable to adverse events. During this phase, they develop the right hemisphere, they develop the neural networks. If there were significant adverse events during these years, it can affect how they process social emotional information, how they form attachments, how they regulate body functions, how they cope with the stress. And also, study shows that neural connections between limbic system and the prefrontal cortex are established between 10 and 18 months of age. These neuronal pathways plays a critical role in arousal and emotional regulation. So if during these phase of their development, if the child is not given adequate attention and if they were sensory deprived, these neuronal networks are not forming and the child does not know how to respond to any stressors in the future. Moving on to psychological theory, there's another theory by John Bowlby, attachment theory. So it also explains about how parental relationship or infant relationship with the caregiver is important to develop patterns of relationship or patterns of attachment in the future. Moving on to environmental factors, it says that adverse life events have a significant role in changing the trajectory of a person. Adverse life events in the form of abuse or in the form of a non-nurturing environment or toxic stress, these have lifelong consequences for both psychological and physical health. First of all, we have to assess the patient. We have to assess the severity of the problem. We have to assess their intellectual functioning, their cognitive functioning. How do they relate to others? How is their play? How is they interacting with puppets or dolls? Or how do they interact with caregivers? We also have to get corroborating information from parents and other significant caregivers such as school teachers or grandparents or other significant caregivers if DCS was involved. And looking at the developmental assessment, we check at how do they stand in relation to their norms or to their peers. What is their level of functioning? Moving on to the nursing diagnosis, there's a risk for impaired attachment, a risk for delayed development. Moving on to outcomes identification, you find what is the outcome. Safety is first, then improvement in the attachment of parents and the children. Moving on to the implementation phase, what is your major task? You have to provide safety and stabilization. We have to reduce arousal and help regulate emotion, and develop skills to cope with these stressful situations, and develop social and problem-solving skills. So your main interventions are called the trauma-informed care. So being aware that trauma can have significant adverse effects throughout the child and in their adulthood is known as a trauma-informed care. And so various other interventions are being developed to deal with trauma. That they include cognitive behavioral therapy, eye movement desensitization and reprocessing, and various other psychopharmacological treatments are also utilized to improve the school and social functioning of the children. And finally, we have to evaluate how these nursing interventions has improved the safety and how the child are able to regulate their emotions. Looking at the model of treatment for trauma, it involves some stages. For the trauma-informed care, this model of treatment has few stages. So first stage is to provide safety and stabilization. It is to make sure that the patient is comfortable and has a trusting environment, and safety is important at this stage. In second stage, we try to reduce this arousal and help the patient regulate their emotion through symptom reduction. So here we find help or comfort from others. We identify these suppressed emotions, and this improve their attention and help to work through these memories, these traumatic memories. That is the stage 2. In stage 3 is the developmental and social skills. Okay, catching up on developmental and social skills. Here we are teaching them problem-solving skills, social skills training. Here we further teach them to coping skills to deal with trauma, and also uses healthy social support systems to help regulate these further development of social and developmental skills. So these are the 3 stages through which a trauma-informed care is delivered. So stage 1, you provide safety. Stage you try to reduce this, work through these traumatic memories. And stage 3, we are trying to develop their coping skills and develop their social skills and problem-solving skills so that they are able to deal with any kind of stressors in the future too. So moving on to the next. So what are some trauma interventions for a child with PTSD? Establish trust and safety. Use developmentally appropriate language. Teach relaxation techniques. Help the child to cope with the feelings through art and play. Furthermore, involve the caretakers in 1:1, unless they are the cause of trauma, and educate the child and caretakers about the grief process. Assist caretakers in resolving personal distress. Coordinate with social work for protection. Let's look at this case study. Here, Max, age of 6, has been traumatized by a history of violence from an alcoholic father. A neighbor calls the police one night and the father is taken in for questioning and agrees to enroll in rehabilitation. Max is taken to the hospital for assessment of his arm, which is covered with bruises. His mother is distraught and says she wants to help for the whole family, including her husband. The nurse prepares to assess Max's mental health. So what are some broad areas of mental health assessment for this child? What are the things that you look for? You look for safety, look for the general appearance, look for the socialization of this child, look at his activity level, look at speech, coordination, motor function, affect, manner of relating, intellectual function, thought process and content, and also characteristics of play. So before going home from the hospital, Max and his family begin intervention therapy, which is probably the least useful strategy at this time. Establish trust and safety in the therapeutic relationship. Yes, tick. Use art to help Max explore his feelings. Yes. Bring Max's father to one-is-to-play play therapy sessions. Not really. Teach Max and his parents about grief. Yes. So C is the wrong answer. So because father was involved in the trauma here, right? So it is not appropriate initially to bring father into one-is-to-one play therapy sessions. So which of the following should be established first in working with a child with PTSD? Provide safety and stabilization. Yes. Reduce symptoms. Develop a value system. Alright. Provide support for catching up on developmental and social skills. So here we have to remember the stages of model of treatment for trauma. So based on the model of treatment for trauma, there are 3 stages, right? The first stage is providing safety and stabilization. Second stage is when you try to reduce symptoms. You work through those traumatic memories. The third stage is when you develop value system and provide support for catching up on developmental and social skills. So the first is providing safety and stabilization. So the answer is A. So now moving on to trauma-related disorders in adults. So now let's look at post-traumatic stress disorder in adulthood. Here again, they further re-experience the trauma. Like when you hear about PTSD, you think about veterans, right? So veterans who had exposure to the significant wars and violent incidents, violent war. These traumatic experiences, they re-experience this trauma over and over again in their mind. Even though they don't want it to come, it comes to their mind, and they are very hyper alert, and they are very, they avoid certain situations where it reminds them of the war situations, and they have frequent nightmares and frequent flashbacks. Okay, these are called post-traumatic stress disorder. So in post-traumatic stress disorder, they may have intrusion symptoms such as nightmares, flashbacks, or severe physiological reaction upon exposure to cues, or they may have avoidance symptoms. They frequently avoid reminiscing about traumatic event, or they avoid situations that remind them of this traumatic event. And they also have negative mood. Or they may have arousal symptoms such as being hypervigilant or heightened startle reaction. They have disrupted sleep patterns. They have unprovoked irritability or temper tantrums and hypervigilance. So these are some symptoms of post-traumatic stress disorder. So there is avoidance of stimuli associated with trauma. There is persistent patterns of increased arousal, or there may be alterations in mood. Looking at outcomes for post-traumatic stress disorder, first is to manage anxiety, next is to increase self-esteem, and then improve the ability to cope. And in the implementation phase, as we used in children, we utilize the same model of trauma-informed care using the 3-stage model. So the first phase is providing safety and stability, second stage is to reduce symptom, and the third stage is to developing the value system or developing the social skills. Moving on to psychoeducation, you talk about how to improve your social skills, how to improve your interpersonal skills. We deal with enhancing self-care, and we promote the patients and encourage patients to use relaxation techniques and avoid caffeine or alcohol. And moving on to psychopharmacology, FDA has approved 2 drugs for PTSD. It is sertraline and Paxil. Paxil is paroxetine, sertraline or Zoloft. These are both selective serotonin reuptake inhibitors. And for children in PTSD, even though FDA has not approved any medication, SSRIs have been used for some behavioral issues in case of PTSD. And again, advanced practice, there's another important therapy that is utilized. It is called eye movement desensitization and reprocessing, or EMDR. And cognitive behavior therapy is another form of treatment that is utilized. So EMDR processes traumatic events through a specific 8-phase protocol. So the advanced practice nurse asks the patient to think about the traumatic event. At the same time, the patient attends to other stimulations such as eye movements, audio tones, or tapping. So the combination of thinking and other stimuli bring about neurological and physiological changes that help people process and integrate traumatic memories. To practice EMDR therapy, you need to undergo a specific training as well. And other type of treatment that is utilized is cognitive behavioral therapy, that is using cognitive techniques and behavioral modification and stress management and exposure therapy to help the child and adults manage behavior and change maladaptive beliefs and thoughts. So moving on to what is acute stress disorder. Okay, when we talked about PTSD is only when the symptoms are chronic, like more than 1 month. At least the symptoms have condition lasted at least 1 month. That is when we call PTSD. But acute stress disorder is immediately after high traumatic event. There's a traumatic event and you have the symptoms of the disorder same as that of PTSD, but the symptom duration is only lasting to 3 days to 1 month. Okay, symptoms persist for 3 days to 1 month. That is called acute stress disorder. So the diagnosis is made within the month of after exposure to the traumatic event. So after 1 month, the acute stress disorder is resolved or it becomes PTSD. If the PTSD, these symptoms, the intrusion symptoms, avoidance symptoms, or arousal symptoms, or negative moods lasted for more than 1 month, it becomes PTSD. But before that, it is called acute stress disorder. Next is adjustment disorder. Okay, so before looking at adjustment disorder, let's look at what are these interventions that we use in acute stress disorder. So establish therapeutic relationship, assist to problem solve, connect person to support systems, collaborate for coordination of care, ensure and maintain safety, refer to a licensed mental health provider, monitor response and adherence to treatment. And advanced practice cognitive behavioral therapy is utilized to change their maladaptive beliefs and change into positive thinking. So what is an adjustment disorder? Here, within the 3 months of the onset of the stressor, the patient may develop emotional or behavioral symptoms. So there is a stressful event, and based on the stressful event, the patient has a response. This may be emotional and behavioral symptoms. And this causes significant impairment in social, occupational, and important areas of functioning. And the response to these stressful events may include combinations of depression, anxiety, and conduct disturbances. Remember this question we dealt about a boy whose girlfriend died, and then what are the symptoms the boy was experiencing. We identified it as adjustment disorder, right? Adjustment disorder with depressed mood. So the boy had low mood, tearfulness, feelings of hopelessness, which was predominant, and it was within 3 months of occurring of the onset of the disorder. And these symptoms should not prolong more than 6 months. So after the stressor and its consequences have ceased, these symptoms should not last longer than 6 months. So that is the key criterion for adjustment disorder. So the presence of emotional and behavioral symptoms in response to an identifiable stressor is the essential feature of adjustment disorder. The stressor may be a single event or may be a multiple stressors. Example for a single event is termination of a romantic relationship. Multiple stressors may be marked business difficulties and marital problems together. Well, now we will look at something else called dissociative disorders. So an essential feature of this disorder is a disruption in the integration of consciousness. There is disruption in memory, identity, or perception of the environment. So these occur after significant adverse experience or trauma. And these individuals respond to stress with severe interruption of their consciousness. It is an unconscious defense mechanism. It protects the individual against overwhelming anxiety through emotional separation. So there is overwhelming anxiety, and in order to protect themselves from this overwhelming anxiety, these persons tend to dissociate or kind of move away from that conscious level of awareness. So what are the different types of it? There's dissociative identity disorder, dissociative amnesia, or depersonalization or derealization. Let's look at depersonalization, derealization disorder. In depersonalization, here the focus is on the self. It's the feeling of being an observer of one's body and mental processes from an outside. Like you are observing your own body and mental processes like an external person. Here the person feels mechanical, dreamy, and detached from the body. For example, the patient may feel like, I am no one, I have no self. I know I have feelings, but I don't feel them. My thoughts don't feel like my own. My head is filled with cotton. I feel like a robot. I'm like an automation or something. That is the depersonalization. Whereas derealization is focusing on the outside world. For example, person feels that he or she is in a bubble or a fog or a dream, and there's a glass wall between the individual and the world around them. So he is looking at everything from being inside this bubble, and he's protected inside this bubble and looking at the outside world. So that is known as a derealization. So what is this difference between the delusions or hallucination? How is it different? Here, the reality testing is intact. Patient knows that it is not real, or patient knows that I have my own body and these thoughts are not real. That is the difference between delusions or hallucinations versus depersonalization or derealization. Another one is dissociative amnesia. So what is dissociative amnesia? Here the patient has inability to recall important personal information, often of traumatic and stressful nature. Sometimes the patient does not remember what happened this period of time, or patient may not completely forget who she was and will travel somewhere and cannot remember his own identity. That is known as dissociative fugue. It's a subtype of dissociative amnesia. Here the patient forgets about the past and travels and starts as a new identity. There's a sudden unexpected travel and inability to recall one's identity. That is known as dissociative fugue. Then there is dissociative identity disorder. Here, the presence of two or more distinct personality states, and each alternative personality has its own way of perceiving, relating to, and thinking about self and the environment. So that is known as dissociative identity disorder, multiple like split personality or multiple personality disorder. So these are responses to acute stress. So how do we assess the patient? We have to obtain proper history, we have to assess the mood, the impact on the patient and the family, we have to assess self-mutilation and suicidal risk, and also self-assessment, because self-assessment as in my own feelings towards this patient, am I being manipulated? Is it true that the patient is having these feelings? So my questions, and I need to maintain professional boundary and have respect for the patients. So all these part are very important to develop a proper identification of dissociative disorder. And we have to also assess for any organic issues that causing these problems as well. So what are some interventions that you can do? One is psychoeducation. You have to teach about grounding techniques or coping skills. So grounding techniques that can be utilized include stomping feet, taking a shower, holding an ice cube, exercising, deep breathing, or touching the fabric on a chair, or even writing a daily journal. So these grounding techniques and writing journals and coping skills can be helpful for treatment of dissociative disorder. It's a pharmacological intervention. Even though FDA does not approve medication specifically for dissociative disorder, medications such as anti-anxiety medications or antidepressant medication, SSRIs, or antipsychotic medications or benzodiazepines have been successfully utilized for the treat manifestations of dissociative disorder. And advanced practice interventions like CBT, exposure therapy, EMDR therapy, hypnotherapy, and somatic therapies have been utilized for treatment of dissociative disorders. Let's look at this question. A nurse assesses a patient diagnosed with dissociative identity disorder. Which finding would be likely part of the patient's history? Travel to a foreign country, physical or sexual abuse, thyroid dysfunction, or eating disorder? If you said B, that would be the right answer, because significant physical or sexual abuse before the age of 6 years had been associated with dissociative identity disorder. And these disruptions in identity may be characterized by 2 or more distinct personality states. And there's recurrent gaps in recall of everyday events, important personal information. And this causes significant impairment or distress in social, occupational, and other important areas of functioning.